I'm Peter Block, and it's Sunday here in Philadelphia at the AHA annual meeting. Sunday is the day after ischemia, isn't that right, folks?
Yeah.
Deepak Bach, who's way on the left from the Brigham and Women's, and John Spurtis, who's in the center from Kansas City, and I were just chatting, and we decided we would do what we're going to call ISCHEMIA Recap, because Deepak and I yesterday talked about ischemia. Candidly, we didn't have the quality of life data, and we said, well, ischemia is an interesting trial. It doesn't really show us that we should do PCI in a lot of patients, and maybe this is sort of a negative trial, et cetera, et cetera. We were sort of down on it a little bit. We didn't have the quality of life data. John Spurtis presented it, and now suddenly ischemia turns into a, wait a minute, we make patients better trial. And so we want to talk a little bit about this because it's important that everybody out there understand that ischemia, though the primary endpoint did not make a big difference between patient populations, it turns out quality of life is the big hitter. So Deepak, I'm going to go to you to start with.
Absolutely, and I think quality of life is big in general in medicine. Assessing it is important. Dr. Spurtis has been a leader in the field as well as in the ischemia trial. But I'd like to say one thing to our audience before launching into ischemia particularly. You know, I don't know if our viewership totally understands or even trialists understand how we pick what we cover. You know, sometimes maybe they think it's arbitrary or maybe we're going with your friends. And, you know, but in fact, really what we're doing is covering what we think is going to be of interest to our viewership, what we think is important, and where the trialists give us the slides ahead of time, because of course, if we don't have the material, we can't cover it. So, you know, that's how we decide actually what gets covered. But at any rate, quality of life, important. And in ischemia, it looked like a home run. I mean, it actually looked like that's what the story really was and should have been about.
Well, let me just add one other thing, and that is quality of life actually was a two-pronged outcome here in the chronic kidney disease group, right, number one, right, John? And then in the general group as well. So I'm going to turn it to John and say, John, give us the short version of quality of life here, because our job is to make people live longer if we can. Hard to do sometimes, but also to make people feel better.
Well, thank you both for the opportunity to discuss ischemia. And I do think quality of life is, you know, from patients' perspective, often the most important outcome. And, you know, this was a trial that really rigorously collected and followed the quality of life of patients. And what it really revealed, and, you know, other studies have shown early benefits in terms of quality of life from angioplasty, for example. Here, in a combination of going to the cath lab and getting whatever revascularization strategy, which is a quarter of the time bypass surgery, we found very early and most importantly and most uniquely very sustained benefits in terms of quality of life as assessed by the Seattle Angina Questionnaire. And importantly, we found that the benefit was really quite proportional to the baseline angina patients had. So asymptomatic patients did not really benefit in terms of quality of life, nor in terms of survival, but
because it's hard to make an asymptomatic patient feel better.
I know when I tell my mom that I discovered this, she rolls her eyes like, "This is what I sent you to medical school for." I mean, it's you know, it seems so obvious, but yet in practice, you know, in the NCDR, 20 to 25% of all patients undergoing for stable disease, not the ACS, which is a minority of our patients, but of all those patients, about 20 to 25% are asymptomatic.
And can I just ask, Peter, is that going on at your shop? Because I'll say at our shop, the only sort of asymptomatic folks that we're really doing are the pre-transplant. You could debate whether they should or shouldn't have it, but we do it because the surgeons make us do it. But other than that, in 2019, are you doing it or not?
The answer is, short answer, no.
Yeah.
Yeah, not very many anyway.
Right.
I mean, occasionally somebody will get a CT scan and then get a, you know, a stress test and they've got big anterior ischemia and we say, maybe we ought to take a look.
Sure.
But
Same
it's
here.
unusual.
So all I'll say is that either you practice in very unique environments or, you know, we as clinicians sometimes, you know, don't really sort of recognize what actually is happening and if it's us or our colleagues or whatever. But in the NCDR, when we look at 1,500 hospitals throughout the U.S. and realize this is in the era of appropriate use criteria, right? So you're really dinged if you say the patient's asymptomatic. And you look at what people report in NCDR as asymptomatic, it's, you know, about 12 to 15%. And then if you look at the class ones and even some of the class twos, we know that there's tremendous upcoding in the era of appropriate use criteria. Sure. And so I'm conservatively guessing that we're doing angioplasty at 20 to 25% of our stable patients. Now realize that's a small proportion compared to the ACS population, but it's happening. estimate about 75,000 procedures a year are happening in asymptomatic
And
patients.
can I just ask you, because there's someone in the audience that's dying to ask this question, so I'm asking for them. Is it conceivable, though, that some proportion of that is just miscoding? That is, that hospital
course.
doesn't have the resources to have a nurse go through to make sure that angina is checked off where it should be?
No, there's no question. And what it harkens to is maybe we need to start systematically measuring our patient's health status with the Seattle Angina Questionnaire. I mean,
That's
you
a good
could do a SAC before the procedure at follow-up. I think it would make a huge impact.
Let's cut back to ischemia for a moment. So aside from the asymptomatic patients, many of the ischemia patients had class 2, maybe sometimes class 3 angina, but relatively low-grade angina on balance. All of those patients got better anyway. That's an important point. So cut to the chase for the results of ischemia from your point of view, John. Give me a 3-sentence, what does ischemia tell you about taking care of patients?
So what it tells me is that once I have a diagnosis of coronary disease and I've excluded left main disease, then I'm going to put my patient on optimal medical therapy and try and control their symptoms. If I control their symptoms, I'm done. If they still have angina and it bothers them, then I send them to the cath lab to define their anatomy and figure out what revascularization procedure is best for them, given that I know that I can make them feel better going that pathway because that's what we saw in ischemia, and that benefit can last for a long time.
Okay, and I'm going to add one thing to that, and that is when you look at the ischemia data, now that we have it all, right, and we can actually be smart about this, or try to be, if you are in the control group where you don't get a PCI, you still, over the course of 4 years, have a roughly 25% chance of needing a PCI in that interim. So you have to tell a patient, if you're going to go on the medical therapy side, you know, you're not going to live longer, but you're going to need something done 1 in 4 in the next 3 or 4 years. Is that a fair statement, John?
I would probably disagree with you a little bit. You know, we view these decisions as they only happen one point in time, but we have a longitudinal relationship with our patients. I think we say, let's try medicines,
Well, that's
see
the same
how
thing,
you
right,
do,
yeah. And if you don't-
and you know, and then if as soon as they have bad symptoms, the nice thing about it is, God forbid they do have a complication, you know, AKI, bleeding, whatever,
It happens.
and you know you've already tried every other alternative,
You feel
and so
better.
this was the best time. You feel better, the patient feels better, their family feels better because we tried. This is all we could do to get the grandma or mom or dad alleviated of their angina and improve their quality of life. And they had a complication. It's a bummer, but you know we tried everything else, and this is all we could do.
That's a very sensible approach. You know, you had mentioned before that even patients with mild angina had improvements in quality of life. Could you just quickly expand on that point?
So what we found is that the benefits were quite large, and we use the Seattle Angina Questionnaire to quantify angina, and a score of 100 is no angina. A score of 90 is probably 1 episode a month, and 80 and 70 are several episodes a month, and then when you get 60 and below, you're talking about weekly and then daily angina. Except for the patients with sort of scores of 90 and 100, there were really large benefits from, in terms of being rendered angina-free. And so I think that, in a patient in 1 episode, I don't think you need to rush to the cath lab. But if they have several episodes a month, especially if you've tried medicines, you are really offering them advantage taking an invasive strategy.
Well, I think the several a month can be deceptive because they might only be having, just not frequent angina because they're not doing a lot because they don't want to provoke angina. But I have one other question that came up in the Axel room. A bunch of different cardiologists were asking this question at the table. Maybe they didn't want to come up and ask you all that were ischemia investigators. The quality of life stuff is very clear, but in terms of the main trial findings, how does that move the needle compared with where we were with Courage?
Well, so what's really different about this trial than Courage is that, our traditional role of deciding to go to revascularization, I think we all presume there would be a benefit in terms of survival and quality of life, and it would be most easy to detect in the patients at greatest risk of dying or having a heart attack, which is the highest ischemic group. And so we preferentially selected the highest risk patients. I think it applies to all patients, because if you're not seeing a benefit in the highest risk patients, why would you
Sure
see
not
one
gonna
in the
see it,
low?
right.
And so, from my perspective, what
I'm going to
this-
challenge that in a moment, but I'll
but
let you finish
from
your
my
thought.
perspective, how this really moves the needle forward is that it is directly figuring out in the patients in whom we expect the greatest benefit, and secondly, it randomized patients before they were on the table. And to put somebody on the table and then take them off the table to engage in shared decision-making isn't respecting the patient's body time, et cetera. And
Right.
so labeling these things to happen before you do the diagnostic angiogram was a really important thing that was not addressed in COURAGE or any of the prior trials, which you needed the angiogram first before you could figure out eligibility. And if you're an interventional cardiologist and you think the patient needs it and you see the angiogram, what's going to stop you?
That's a good point.
One last question for you, Deepak. You
Okay.
said you had one more.
Well, you said that we'd expect perhaps that there might have been a reduction in mortality. I don't know that I was necessarily expecting to see a reduction in mortality after COURAGE here. But regardless, though, the COMPLETE trial, which I'm comparing apples and oranges, I know that, but that was a patient population with ST elevation MI, so you could say high risk. They came in with a STEMI. Opening up their non-culprit lesions, assuming they were severe on an angiogram, and if needed, confirmed with FFR in terms of severity, in terms of ischemia, there was a significant reduction in MI that occurred not early on, but rather late with longer-term follow-up. Doesn't that, though, prove that at least in that circumstances, and maybe those are folks with angry plaques, though the benefit was late, not early, that opening up a quote-unquote stable lesion that's tight and ischemia causing, if it's not clear that it's tight, should provide some benefit? And didn't you see some signal of spontaneous MI being reduced?
So first of all, we published, data sort of looking at the completeness of revascularization at the time of a STEMI and treating the non-culprit artery on angina and quality of life, and we saw benefit there. So I think there are advantages of that, but you're positing that, sort of an interesting hypothesis off of a trial in a different population is the same as a huge trial specifically asking this exact question. And I think you can't compare that, sort of a secondary, interesting, and provocative interpretation. If there were no ischemia trial, that would be a great foundation to argue to do an ischemia trial. But now we've got the trial, we've got the data, and I think it should inform the way we practice going forward.
Okay. So there you go. This is an ischemia recap. Now that we have all the data, it's a little easier, isn't it?
A little bit easier.
And so with the quality of life data now and John's wonderful interpretation, we know that ischemia has a lot to offer, or the trial has a lot to offer all of us taking care of patients in terms of making them feel better. They may not live longer. Angioplasty never saved a life in its life, is what I always say, except in acute myocardial infarction and ACS possibly. But for stable chronic angina, patients feel better if they have a PCI, and John has shown us that very clearly. Thank you very much.